pleasure to introduce Dr. Jenny Petkova. Dr. Petkova is an assistant professor of clinical medicine at the Academic Institute at Houston Methodist and Will Cornell Medical College. She is a classical hematologist who enjoys long discussions about thrombosis and hemostasis. Without further ado, Dr. Petkova.
Hi, everybody. Thank you so much for inviting me today to talk about antiphospholipid syndrome and its role in pathogenesis and occurrence of stroke. And I guess I'm doing something wrong because this is not moving. I have Neanderthal genes. Sorry.
A bit tricky,
It required a neurology touch. Anyway, I don't have any conflict of interest, and I would like to start with a short presentation. So this is a 62-year-old lady with past medical history of recurrent DVTs, hypertension, hyperlipidemia, admitted for new onset, left-sided weakness, and obviously found to have acute ischemic stroke. She underwent thrombectomy because she was already on anticoagulation, and she had significant clinical improvement. She had been on warfarin after her second DVT in 2010, and both of the events were unprovoked, and so they determined that she'll need long-term anticoagulation, but was recently switched to apixaban about 6 months prior. This was the beginning of the COVID pandemic, and warfarin management was even more challenging than it usually is. To patients and her family knowledge, she didn't have any prior history of thrombophilia. So she did have thrombophilia panel done while she was hospitalized, and obviously we checked for inherited thrombophilias, which I admit is not necessary in patients with stroke, since those are not associated with arterial thrombosis. And not surprisingly, in this case, the inherited thrombophilia testing was negative. However, if we take a look here at the cardiolipin, beta-2-glycoprotein, and the lupus anticoagulant itself, all of these are positive. So a possible antiphospholipid diagnosis was made. So what is antiphospholipid syndrome? It's a poorly understood autoimmune disease which is characterized by venous or arterial thrombosis and or pregnancy morbidity in the presence of antiphospholipid antibodies that persist over time. So it's a very descriptive definition which tells us that we probably don't know exactly how the disease works. Epidemiology, it's a very rare disease. Incidence is 1 to 2 cases per 100,000 individuals. Prevalence is 40 to 50 cases per 100,000 individuals. The presence of antiphospholipid antibodies without thrombosis or pregnancy morbidity are fairly common, especially in patients with autoimmune diseases. In lupus, 30 to 40% of the patients have such antibodies without any clinical manifestations. 2 to 4% of healthy individuals without any disease also can have positive antiphospholipid antibodies. So the mechanism, as I already admitted, is poorly understood, but for some reason we have the B cells producing these antiphospholipid antibodies. This, in fact, is a misnomer. They don't bind antiphospholipid. They bind glycoproteins, such as beta-2-glycoprotein 1 in this case. And when bound to the antibodies, the glycoprotein changes its conformation, it dimerizes, it can bind cell surfaces and causes all sorts of changes. Some of those changes include increased expression of tissue factor on monocytes and endothelial cells, increased C-selectin and other adhesion molecules on the endothelial cells, VEGF, as well as netosis of the neutrophils. In platelets, these antibodies increase the expression of glycoprotein 2B3A, the main integrin of the platelets, and then they decrease various anti-clotting factor pathways with TFPI activity decrease, protein C activity decrease, and then overall decrease of fibrinolysis. The effect is even less understood on the placenta, but ultimately you have again increased complement activity, decreased proliferation of normal syncytia, and trophoblast apoptosis. Clinically, this results in inflammation, vasculopathy, thrombosis, both venous and arterial, as I mentioned, as well as pregnancy complications. So the classification is based on the clinical presentation, based on the fact the patient has thrombotic complications, obstetric, or catastrophic antiphospholipid syndrome is a very rare, luckily for all of us, catastrophic complication presenting with macrovascular and microvascular thrombosis multiple organ systems simultaneously over a very short period of time. So to go over a little bit more in detail about the thrombotic manifestation of antiphospholipid syndrome, most common thromboses are venous. More than 30% of all patients present with DVT, another 10 to 15% with PE, and about 9% have superficial thrombophlebitis. We'll talk about the incidence of other arterial events next slide, but they are not as common. And as you can see, catastrophic antiphospholipid syndrome is extremely rare. So the most common events associated with antiphospholipid syndrome are actually ischemic stroke and transient ischemic attack. And based on the studies published, the prevalence of stroke is about 15% and TA about 7% of all patients. In younger populations, antiphospholipid syndrome may account for up to 20% of all strokes. And if we just look at the time of diagnosis, antiphospholipid testing can be detected up to 13% of the patients with acute stroke. 14% of these patients have isolated IgM-only antibodies, and these can be persistent in 70% of the patients satisfying the criteria for antiphospholipid syndrome. So the diagnostic criteria are fairly complex, sorry about that. They were all devised by rheumatology and applied by hematology. Sorry, but the first one attempt was in Sapporo, 1999. These were modified in 2006 in Sydney. They are still known as the revised Sapporo criteria, and these are the set of criteria currently in clinical practice. The new proposed criteria from last year, again from the American and European Societies of Rheumatology, they are designed for research purposes only, though we are going to use them clinically, I'm sure, shortly. So what are the revised Sapporo criteria? They are divided into clinical and laboratory criteria. Clinical criteria include vascular thrombosis with any thrombotic event, arterial, venous, or small vessel thrombosis, qualifying as such, and then pregnancy morbidity, second trimester pregnancy loss, eclampsia, preeclampsia, or other features of placental insufficiency, or 3 or more early pregnancy losses, and they have to be consecutive. The laboratory criteria need to be established within 5 years of the thrombotic or pregnancy-related manifestation. So anticardiolipin, IgG, and IgM, anti-beta-2 glycoprotein 1 and IgG or IgM are the two sets of antibodies currently included in the classification criteria. The IgA isotype is not considered specific or sensitive enough, and hence it was not included. There is a slew of other antiphospholipid antibodies. They are also not included, again, due to poor sensitivity and specificity. These need to be significantly elevated, so more than 40, since the labs never give us their percentile, so the current accepted level is more than 40 to be clinically significant, and they need to be repeated at least 12 weeks apart to make this diagnosis. Now, lupus anticoagulant is a functional assay. It's obviously a misnomer. It has nothing to do with lupus. But it needs to be done based on specific assays defined by the International Society of Thrombosis and Hemostasis, and again, it needs to be positive for at least 2 or more occasions, 12 weeks apart. It relies on PTT variations, and it needs to be prolonged in the presence of phospholipid. That's how the assays work. So the new criteria, they are weighted actually. So now you have to have 3 points in the clinical domain and 3 points in the laboratory domain, and I emphasize this is for research purposes. They still kept the macrovascular venous and arterial thrombosis, but now they are weighted. If you have a VTE with strong provoking risk factors such as surgery, you only get 1 point. The same thing would apply for a patient with acute stroke who has multiple other risk factors for stroke. They also included specific microvascular criteria, as you can see here. The obstetric criteria remain fairly the same, they're just weighted differently. They also allow for cardiac valve involvement as one of the criteria, and for thrombocytopenia, because about 30% of these patients have thrombocytopenia. The laboratory criteria based on this research recommendation criteria need to be established within 3 years of the clinical manifestation. They include lupus anticoagulant. If it's positive only once, it doesn't satisfy the criteria. And then the different antibodies need to be either moderately positive, more than 40, or high positive, more than 80. The concerning thing a little bit here is that if you have only IgM positive, the patient only gets 1 point. And like I said, about 13% of stroke patients present like that. So the main kind of body of the talk is about treatment of these patients, obviously, because most of them present with venous thrombosis. Warfarin has been the standard of care, with the big debate being whether we should use standard or high intensity anticoagulation, so 2 to 3 versus 3 to 4 INR. And this is the first randomized controlled trial from 2003 that kind of gave a rather definitive answer that there is no difference in outcome regardless of which group you look at, whether it's arterial, venous thrombosis, patients have lupus SLE, or they have lupus anticoagulant. So one study probably wasn't enough, so this was the WAP study that came out 2 years later, which pretty much reported the same outcomes. There was no difference in thrombotic complications. There might have been a little bit of increase in minor hemorrhage, but nothing else was statistically significant. The same study also included a meta-analysis of the Canadian consortium and their own data. And as you can see here, again, there is no statistical difference between patients managed with standard intensity or high intensity INR, hence establishing the standard intensity as a standard of care. I feel rather embarrassed about talking about antiplatelet agents to this audience, since you guys know significantly more than I can aspire. But these are the few options that have been looked at, and the data is very limited, with this being the randomized control trial back from 2004, which was actually a nested study within the WAR study, where patients with stroke were randomized to warfarin versus aspirin. And they also looked if some of these patients had positive antiphospholipid antibodies at the time of diagnosis only. And so these are the patients that were included. This is the two arms, warfarin and aspirin. The dark lines are the antiphospholipid positive, and the light line is the antiphospholipid negative patients. And this is the probability of recurrence, and as you can see, there is no difference between the two. This is not in a graph format, but it pretty much suggests the same, that whether you manage these patients with warfarin and aspirin, there is really no statistical difference in outcomes, and they looked specifically whether there was interaction between treatment and antiphospholipid testing, and there was none, regardless of how the analysis was done. So the dual antiplatelet therapy, this is the one study that I found, retrospective cohort, single institution study from Sapporo, Japan, of all places, that looked in punctate here in the dual antiplatelet therapy, here in the warfarin with antiplatelet agent, warfarin single agent and single agent antiplatelet therapy. And as you can see, the patients who had either dual antiplatelet therapy or combination with warfarin had the best event-free survival. Very small study, again, I emphasize retrospective, etc., but that's the results. Now, this is a bit different from the study that came a little bit before that from the US. This one was 2 clinical databases, again, retrospective, again, small numbers. But here in green, you have actually the best outcome, so the highest number of patients without recurrence in patients who are on combined therapy, with antiplatelet therapy having the highest recurrence rates. Now, this was not stratified into single versus dual antiplatelet therapy, and they also didn't tell us what the recurrent events were, whether they were arterial or venous. But seems that also this suggests that maybe combination would be preferable. Patients who don't cover clinical criteria for antiphospholipid syndrome but have positive antiphospholipid testing pose a separate challenge, and in those of them that have also lupus, there is good data that low-dose aspirin, based on randomized controlled trial, that low-dose aspirin is actually protective from thrombotic events. But in individuals without diseases, asymptomatic patients, this is not clear. There is a meta-analysis that looked at these patients, and for the high-risk patients who have all three tests positive, there might be benefit from aspirin. There is also increased risk of bleeding as well now from aspirin. So I did something wrong again, I guess. Okay. And finally, the role of DOACs in patients with antiphospholipid syndrome. The first study that tried to answer this question was the RAPS trial from the UK. It was laboratory endpoint trial, and this is the number of patients that were randomized to each arm. As you can see here, in patients on rivaroxaban, the endogenous thrombin potential was much higher. Clinically, there was no difference in the thrombotic events between the two arms. And so the Italians were the first one to publish a randomized controlled clinical trial looking into rivaroxaban versus warfarin in patients with antiphospholipid syndrome, which were higher risk, triple positive patients. 59 in the rivaroxaban and 61 in the warfarin arm were enrolled before the study had to be terminated early because of excess of thrombotic events in the rivaroxaban arm. And when we look at what those events were, they are all arterial events, with ischemic stroke being the most common one. As you can, this is regardless how the analysis was done. So the next study doesn't have a nice name. It came from Spain, and this is their patients. They included all their patients with antiphospholipid syndrome, regardless of whether they are triple or single positive. So this is a little bit higher number study. And again, they randomized them to warfarin versus rivaroxaban. And as you can see here, the incidence of specifically arterial events is significantly higher in patients who are on rivaroxaban, and specifically the incidence of stroke. Again, based on how we do the studies, but this is statistically significant regardless of the statistical maneuvers. The final one was the study from the US that came out 2 years ago, and it compared warfarin versus apixaban. It's a questionable design study, I admit, because they initially randomized patients to 2.5 PID of apixaban, which is prophylactic dose. So they had to pause it and increase the dose, and they had to pause it again and exclude patients with prior history of arterial events. And with all these maneuvers, they were able to enroll just shy of 50 patients. Only 30% of them were high-risk patients, and as you can see here in the graph, at 12 months, there was significantly more patients who had a stroke in the apixaban arm compared to warfarin, which resulted in the study being prematurely terminated. So when we look at what type of stroke or what type of ischemic events the patients had, they had ischemic stroke, all of them. The one that was on warfarin had a bleed. And when we look, some of them were single positive, some of them were double positive, and some of them were triple positive, so various risks. And more importantly, not all of them had prior risk of stroke. So this patient and this patient, although they developed stroke, they only had history of DVTs. And a meta-analysis tried to make this a little bit more palatable, pulling the data from all 4 trials. And as you can see here, the composite arterial thrombosis risk and specifically stroke was significantly higher in the 2 DOACs. And they tried to look at the different studies individually, whether myocardial infarction was any different. Only in the Bengal study, the Italian study, there was a difference. All the studies, there was increased risk of stroke. They did try to look at triple positive, single and double positive, whether they had history of arterial thrombosis or not, men or women. And as you can see here, in all patient groups, there is increased risk of thrombosis in patients with the DOACs. So based on that, DOACs are not recommended for these patients. And our poor patient was switched back to her warfarin, and we added low-dose aspirin, and she has not had a recurrence for the last 3 years. And these are my references, and I guess we'll do